selecting the.
Sorry about that.
That's fine. Let me close some windows.
If you want to do this sort of like belt and suspenders, let's make sure if you want to send me your slides, just in case.
Let me do that now. File, save. Download that. Okay, so I saved that. Let's send to Deb. Apologize. Why? Now I'll start sharing screen. I think that email should be going off. Put myself in slideshow. It's never quite the way I want, but hopefully.
That looks perfect.
Okay.
So I'll give everybody a couple more minutes.
That sounds great. Your series sounds really good. I feel like I should look back and see all the great speakers you've had.
You can do that on our website at your leisure. We have all the old schedules loaded up there.
It seems very organized, which I always appreciate. There's so many presentations I want to go to and things I want to do. It's the problem with being an academic. I'm going to change the background.
Rosalind, what do you think? Give her another couple of minutes or get started?
I think you could go ahead and introduce Whitney now. Thank you.
All right. So I can't tell you how thrilled I am to introduce Dr. Whitney Robinson, who will be giving our Pop Health seminar today. Whitney is just an amazingly talented researcher whose voice I think has really become impactful around conversations around COVID and health equity. So Dr. Robinson is Associate Professor at the Gillings School of Public Health at the University of North Carolina. She received her A.B. cum laude from Harvard University and then received master's and PhDs in epidemiology from UNC Chapel Hill and completed a dissertation entitled Under the Same Roof, Understanding Gender Differences in Obesity Prevalence Among U.S. Black and White Young Adults. After receiving her PhD, she was an RWJ Health and Society Scholar at the University of Michigan. And since 2010, she's been at the Gillings School of Public Health at the University of North Carolina, Chapel Hill. I don't want to spend too much time with her introduction. There's so much to say, but I'll highlight she's got an R01 focused on racial differences in treatment with hysterectomy, a multi-level investigation. And she was awarded the 2018 Teaching Excellence and Innovation Award by the UNC Gillings School. Today, she comes to our series and is co-sponsored by the Prevention Research Center. I'm really looking forward to her talk today about how the past year has influenced her work. So please join me in giving a warm welcome to Dr. Robinson.
Thank you so much for the warm welcome. I'm really glad to be here, and I'm glad to have the opportunity to reflect on this past year in my scholarly life. It's been an interesting experience just to think through how my work has changed. Let me, I was actually here visiting you in person in late 2018. And I gave a talk about my gynecologic work. And at the time, I had a 4-year-old and I was pregnant. And now the pregnancy has resulted in a very, very cute, almost 2-year-old. And so having children has helped me really mark the time And I had a wonderful visit with you all then, and I'm really glad to be back. And in that talk, I did some self-reflection about the way that I approach my work. I love talking about the kind of experience of being a researcher and how we think about what we prioritize in the work we do. And in that talk, I was focused on my reproductive equity work and saying that a major motivation that I have is to advance knowledge that matters to somebody. There's so many interesting questions to ask, and we have to prioritize. And I try to use that as a compass for deciding how I spend my time. And I talked about uniquely what I think I can bring to that task. I have a focus on social determinants of health. That's mostly what I study. I bring a diverse toolbox of data, study designs, and methods. I really try to let the problem guide the study design. And my approach is very interdisciplinary and collaborative. And I think you'll see that through some of the work that I talk about today. And so I have a similar frame for this talk. You know, this is the 2021 edition of that 2018 talk, and I still want to advance knowledge that matters to somebody. It's still very important to me. But in this past year, what has felt the most urgent was the public health emergency of the US COVID-19 outbreak. I'm not an infectious disease epidemiologist. I'm not a modeler. I don't have a lot of experience in applied epidemiology and community work. But I did feel called to try to contribute what I do have to bring. And as I looked back on the past year, there are three principles that guided me and where I spent my effort. One is the idea of bringing my best self. And that ties back to the last slide, thinking about what do I have to bring? I'm not an infectious disease epidemiologist. I'm not going to start pretending to be. You know, nobody needs that. Nobody needs somebody, you know, getting into a field without the expertise to do a good job. But I do have some skills that I can bring to questions that are relevant for the outbreak. Another principle is go where the people are. And I'll talk a little bit about changing my approach to dissemination of information. And then the idea of continuously reevaluating myself and the field. Throughout this outbreak, I've really thought about how can I best serve my community and my family. And it is a constant shift because there's so much need. There's also the need to take care of ourselves. And it's an ongoing challenge. And so I've reflected a lot on my own personal role as a scholar, but also on my field, specifically epidemiology. And so the idea of bring your best self, I'll talk about a few exemplar projects that I've engaged in. Go where the people are. I'll talk about outreach and dissemination to various target audiences. And the idea of continuously reevaluating myself in the field. I'll focus very briefly on an AJE article I wrote this summer about epidemiology's role in structural racism and inverse hazard law in occupational settings. So number one, bring your best self. So here we are in the middle of a really tragic outbreak, an uncontrolled outbreak with a real gap in leadership. That's where I found myself in 2020. And what I do best is applying fundamental epidemiologic principles to understand causes of health differences across diverse socio-demographic groups. That's kind of my bread and butter. It's what I do well, and it's where I think I can add value. And my first foray into research around COVID was actually inspired by one of your faculty members, Dr. Tiffany Green. So Tiffany and I were on a phone call about something else work-related, and she mentioned the study. And it looks a little fuzzy on my screen, but it was one of the hallmark studies of the epidemiology of COVID-19 among children. We owe a great debt to Chinese scientists. They formed so much of the bedrock knowledge about everything we know about COVID. And it's just hard to overstate that. And in those early days, the literature, any high quality literature about health effects in COVID really was coming from China. And so this was a paper published in Pediatrics. And what actually caught my attention more was a commentary on the paper, more than the paper. So a commentary on the paper included that preschool age children and infants were more likely to have severe clinical manifestations than older children, you know, teenagers. And so Tiffany was saying she had a friend who was pregnant who was really scared, who was really worried, about outcomes for her pregnancy and her child. And I think in public health, we often don't think about our bedrock values and how they influence the work we do. But one of my values is that the perinatal period is one of some vulnerability, and anything we can do to support and help people in that period is worth doing. And that's just a positive value that I have. And so anything that is going to add stress that's not helpful to somebody, I think is a negative, a net bad. And so anyway, this study and the commentary had really concluded that young children and infants were really vulnerable to very severe outcomes from COVID-19 infection. I had been paying a lot of attention to this because, again, at that time, I had young children. I had preschool age children, a 5-year-old and a 1-year-old. And so that wasn't, the conclusion of that paper wasn't what I had necessarily been seeing in the literature. One of the things that really caught my attention when we expect a lot of respiratory viruses to be worse among children and the elderly, and we definitely saw the awful impact in the elderly, but when we looked at outcomes for death and severe illness for the youngest children, we weren't seeing that elevation of morbidity and mortality that we usually see among the very oldest. And so the fact that this paper was finding something so different caught my attention. And so I'll briefly talk about the paper, and it really does bring you back to situating where we were in early 2020. These researchers and doctors were working with an uncontrolled outbreak of something they had never seen, a completely novel human pathogen. And so they are trying to triage people. They are able to do some PCR because of the work of Chinese scientists in making the sequence for the SARS-CoV-2 virus, but also they don't have enough to do PCRs on everybody and not enough time. They just need to treat people. And so with this pediatric population, there were actually 2 case definitions. One was a case definition for a confirmed case, where you suspected they were a case, and then they had a swab. They basically had a test that was showing the presence of the virus. But there's a large group of people who were suspected cases. And it was if the child had been exposed to a case in the past 2 weeks and was basically sick, had a fever, or had an elevated white blood cell count, or an abnormal chest x-ray. And even if the child hadn't had a positive case exposure, that they were sick and it didn't seem like it was the flu necessarily. So these case definitions are going to come into play. So I went back and reviewed this paper that was saying that preschool age children really had high morbidity from SARS-CoV-2. And one of the first things I noticed was a difference between this confirmed category and the suspected category. So severity of illness is really the outcome here, ranging from asymptomatic, no symptoms, all the way to critically sick. And one thing you'll notice is that the asymptomatics were all concentrated in the confirmed cases. So the only people in this data set, by the case definition, who are going to be asymptomatic are people who have a confirmed diagnosis of SARS-CoV-2, because to be a suspected case, one of the requirements is that you're sick. And so here on the right side, this arrow going up shows that if you combine the confirmed and suspected cases, a greater proportion of the infants and the 1 to 5 year age group are in the suspected category. And then overall, you do see a lot of severity. And so another thing is that there's a lot of differences between these confirmed and suspected categories. So as I said, the youngest people were more likely to be in the suspected category, and the older children were more likely to be in the confirmed category. And so when we think about this relationship between age and illness severity, there's this critical third confounding factor about how they came to be categorized and whether they were really a true case. So we know that all the asymptomatic people are in this confirmed case group because none of the asymptomatic people could be in the suspected case group because of the case definition. And so when we have this proportion of the young children who are in the severe and critical, it could be a lot of suspected cases that were not confirmed. And the issue here is that some of these suspected cases could be due to other viruses that traditionally do cause great morbidity in young children, like RSV and adenoviruses. And in the Dong article, the main article, they said that they couldn't rule this out, that they did a rule out for flu, but some of these children who were coming in, who were having severe morbidity, could have had a higher prevalence of these other viruses, and maybe it wasn't SARS-CoV-2. So I wrote a letter to the editor pointing this out, and it was online, you know, and it has typos in it because I was just typing it in the middle of the night and I just pressed submit online. And so forever for posterity, you can go and you can see my letter to the editor with all my typos. But this is just an example of me thinking about really basic epi concepts, about competing causes of outcomes, and about the demography of what we do know about respiratory morbidity by age from other conditions, and thinking about fundamental causal inference principles like, you know, positivity. Are there cells where you just, some category of people can't even be eligible to be in that cell? And exchangeability or confounding control. Is there some lurking third factor that is differentially depositing groups in the exposed or unexposed? So, you know, this is a small thing, but it kind of was my first dip into engaging with the COVID-19 literature. Something more formal that I've been doing is actually a seroprevalence study in North Carolina. So early on in the US, we also had a shortage of tests. One of the fundamental things epidemiologists want to know is the incidence of disease. How many people have disease? How many people have had disease? And that question was impossible to ask because we didn't have the testing infrastructure to do that. And, you know, people would do studies where they just look at their hospitalized population, for instance, but the hospitalized population is not representative. A lot of the early studies, you know, said this is only common in old people, but that was who was showing up at the hospital to get tested. And I felt like pretty early on from seeing studies in other countries that there was a large reservoir of young people who had SARS-CoV-2 infection, were subclinical because they weren't sick enough to use precious hospital space, but are really important for understanding transmission dynamics because they're part of communities and they can be people who are transmitting. So this is collaborative work from a lot of different stakeholders. I've gotten to know a lot of infectious disease epidemiologists, people who work in modeling through a wide variety of infectious diseases and lab work, people who do a lot of the like hospital clinical lab work. And this is funded by an award from the UNC Gillings Innovation Laboratory and the State Department of Health and Human Services. And so we were really inspired by surveillance in the HIV epidemic in sub-Saharan Africa, where there wasn't the infrastructure to be able to do massive surveillance testing. And so a strategy that was used was to look at people who were receiving antenatal care and to use their leftover blood serum to see their HIV prevalence, and then to monitor transmission through that population, thinking of it as a sentinel population. I think so often in the US, we think about ourselves as being very advanced, but I think that the COVID-19 experience has been really humbling. There are many countries that have much less wealth than we do who have done amazing because they have relied on strong public health principles. And I, you know, wrote this paper with my colleagues called Learning from LMICs, low and middle income countries, because we are in a situation where our technology is not there to save us. And so we need to be humble and open about learning from countries that have done a better job in monitoring, but also in prevention of COVID-19 effects. And so what I liked about this model, I love reproductive age populations. I generally love women's health. And I think that these populations of people who are receiving antenatal care, they're going to be racial and ethnically diverse in a way that other samples weren't at the time, a young population, a population of people in prime working age, likely asymptomatic more than other populations, so the kind of populations that would be missed. Also, if you think about populations like those who are undocumented, they're not going to enroll in your study to track SARS-CoV-2 infection. And this is a way to represent a more diverse population that includes people like that. And there are some limitations that I can discuss later, but I was really excited about this, especially early on when testing was so limited. So we used leftover blood from routine prenatal labs. There has been a lot of change in prenatal care during this past year, but the official recommendations from the obstetric and gynecologic organizations has been to keep some touchstones as routine. And one of these is the serologic screening for rubella immunity, also screening for syphilis and some other screening tests. We focus here on the rubella screening because it's given one time, so we don't have to worry about all those repeat measures, and it's a first trimester test. So we went through a lab at UNC that runs all the samples for a bunch of clinics that are associated with the healthcare system. And we get through our NC tracks, our CTSA infrastructure, informatics infrastructure, a weekly poll of everyone who's getting one of these syphilis or rubella screening tests and has a diagnostic criteria for pregnancy for the test. And we work with the lab that runs ELISAs. So I'm giving you a snapshot from a period June to November. We have a backlog of samples now, and we're going to be getting a bunch more, and I think we'll see a lot of rising rates in that time period because we saw a huge surge in cases in November and December and January, but these reflect kind of June to late October in 2020. And I think one thing you see is that we do have racial ethnic diversity more than a study if that might have just been like recruiting people. And you see the age diversity. The age is the reproductive age population, and it's about half white, 15% Hispanic or Latina, and 20% Black, and about 5% Asian, with some unknowns and refusals. And our overall prevalence in the population was about 10%, had antibodies. And actually, it was really interesting, even defining what counted as a positive antibody level. A lot of the tests to define positive SARS-CoV-2 antibodies is in sick populations, and a population like ours that might be enriched for people who are asymptomatic or who had very, non-serious disease. It was hard to know where to set this cut point. You'll see there's not a clear, line about where to set this cut point. And so we used a formula to try to, balance sensitivity and specificity and to get a high sensitivity and specificity using control samples from before 2019. Because there is a little bit of cross-reactivity with other viruses. And so setting this cut point was a little bit hard and it's imperfect. So one thing you'll see is that the proportion of seropositive tests rose over time, which is good and kind of fundamental to our ability to use this to track populations over time. And we saw huge racial ethnic disparities. So I said that over that time period ending in late October, early November, our overall prevalence was about 10%. That varied over time, and it varied hugely by race ethnicity. In the Hispanic Latino population, it was closer to 30%. The white and Black populations were closer, but there did look like there might be a trend of a higher rate of new seropositivity in the Black population. There's also some interesting trends in the Asian population, which I probably don't have time to go into. Their seropositivity was even maybe a little bit higher than the white and Black seropositivity. And we have a relatively large refugee population of refugees here in that community and who often work in low-wage essential worker jobs. And I'm really interested in thinking about the burden in that population. And anecdotally, I think that population has a pretty high SARS-CoV-2 prevalence, similar to some Hispanic Latino populations. So we're going to continue this work. The state has really found it useful to have this and is interested in continuing to track these populations to think about antibody response and immunity as we roll out vaccines. That's an important next stage of monitoring the population reservoir that is susceptible to SARS-CoV-2 versus those who have an immune response. We also have another study very similar that we're running with LabCorp, which is a multinational organization that does a lot of the lab processing for federally qualified health centers and for many other facilities that aren't part of a large medical center that would run its own tests. We do have the ability to link to the electronic medical record, and hopefully we'll be able to do that and know more about people's experiences in pregnancy, whether they've been vaccinated, and we might have the possibility to look for seroconversion during pregnancy to see if that had any effects. So I just talked about some of the research I've been doing, and it's not exhaustive, but it's dipping my toe into this infectious disease world at a place where I think I can be useful and not just getting in the way with my lack of infectious disease training. So another thing I've been doing is just more outreach and dissemination. I'm a pretty traditional researcher. Mostly I just publish in my public health, academic, epi journals. But I've been doing a lot of different things in this past year, thinking about literally helping my extended family to navigate this, starting a Facebook group for my cousins and aunts and uncles and just making videos to talk about, what's up in COVID news, working with my neighborhood organizations, but also doing a lot of online outreach as well. So I'm just going to give a few examples. First, I love where I live. So I live in Chapel Hill, North Carolina, which is a college town in central North Carolina, the home of UNC Chapel Hill. And the neighborhood I live in is a historically Black neighborhood. And it's where a lot of the workers who worked at UNC, Black workers, lived. And now it's a mix of student housing and some older people who are still in the neighborhood. One of my neighbors just had a 100th birthday party. He's a World War II veteran who built one of the first houses on our street, Mr. Farrington. And, it was funny. There was a whole thing, like the marching band came down the street and we celebrated his life. And so it's a wonderful community. And a professor and some community members started a not-for-profit, the Marion Cheek Jackson Center, several years ago, and it does a lot of things. One of them is a housing initiative to try to get more families back in the neighborhood, and many other activities, educational and direct service to people. And one thing they do is the Northside News, which is a print newspaper, or print newsletter. And so it's back and front, it's delivered door to door to everybody's houses. So here's a picture of somebody sitting in her kitchen reading the Northside News. And, it's online, you can see the PDFs, but, there's a group of students who volunteer for the Northside News and go door to door and drop it off, every month or two. And, I've been featured in the Northside News, and honestly, it's one of the most important things I do. More people are going to read this and really read it and take it in probably than a lot of my academic journals. But I'm situated in a context that is not just like a health context. It's a context of a publication that matters to the community. So, people have in memoriam documents, they talk about voting, they shout out everybody's birthdays. They talk about how do we feel about the university reopening? It really is a community effort. And I've been really privileged to be able to kind of put my own public health articles in the newsletter and try to just give practical advice and to also try to just be real with people. And I've gotten good feedback from it, but it's not something I never necessarily was doing earlier in my career. I'm also very active on Twitter. And I was always active on Twitter. I mean, I've been on Twitter since 2012, which is odd, but mostly I was, tweeting conferences and stuff. And I've started tweeting a lot more about COVID, have about 11,000 followers now. And a reason I do it is because some of it is me reaching people I care about. A lot of people from my church follow me on Twitter. And honestly, a lot of journalists are on Twitter. And if there's something I think is important, I might tweet about it. And sometimes I'll have journalists reach out to me and say, like, I saw this tweet thread, and they'll pick up something either by interviewing me or interviewing somebody else because of something I've done on Twitter. And I feel called to put my voice out there because I think there has been a dearth of voices who think about health inequalities from a perspective of Black Americans and the burden being faced during the pandemic. And I just realized early on that some of the things that seemed very obvious to me didn't seem obvious to other people, and that it was a responsibility for me to try to publicize things that I think are important. And one of those Twitter threads actually led me to publish an article in an online newsletter. Again, there's so many different modes of communication now. I've been on podcasts, tweets. A lot of professional organizations have blogs, my local neighborhood newsletter, working with advocacy organizations. And so the online newsletter is yet another mode of communication. And this newsletter was started by a professor at UNC, coincidentally, and it really is a coincidence, Zeynep Tufekci, who has a big following, does a lot of popular press, and saw one of my Twitter threads. And I wrote something for her newsletter that was about vaccination, because I felt like the discussion about vaccination was actually taking a turn that was really negative. There was this kind of juxtaposition of speed versus equity. Like, you just have to vaccinate as many people as possible. And any concern with equity and getting to racial ethnic minorities or getting to people who are like in dangerous jobs is just slowing everything down. And as an epidemiologist, I really wanted to point out that if you vaccinate all the rich 68-year-old like hospital execs in the world who, yes, have age as a risk factor, but have very low risk of getting infected, and you leave the 59-year-old hospital janitor or person who lives in a crowded apartment with her grandkids who all work in fast food, you're not targeting the right people. So like, don't pretend like you have the moral authority by just going with this age-based approach that doesn't take any account of who's actually most likely to be exposed. And so I used a jumping off point, a vignette about Stanford residents and their protest against being at the bottom of the vaccination priority list to make a larger point that age isn't the only thing to consider with vaccination. The absolute risk of death is not just based on age, it's based on were you exposed and infected? And so that means that a 60-year-old in a prison in the US can be at higher risk than a 75-year-old person who's a wealthy Stanford hospital executive. And it just feels like such a basic epi point to make, but it's literally life or death when thinking about how we prioritize this life-saving vaccine. So I talked a little bit about some of the work I'm doing, trying to think about, what I have to offer as far as epidemiologic insights. Talk a little bit about using different modes of communication for dissemination. And last, I'll talk very briefly about the constant process of reevaluating myself in the field and the role that we play. Because as a scientist, I am an actor. I think it's very hard to be neutral. I think we don't like to think of ourselves as potentially doing harm, but there is always a risk of doing harm, net harm, even if we have good intentions. And so I wrote a paper with colleagues that argue that some of the emphasis of epidemiology on individual level risk factors for poor outcomes facilitate structural racism and limit accountability for structural causes of ill health, such as occupational hazards. So this quote is from the paper. I think it's from like the last paragraph maybe. And so I say, one of epidemiology's founding legends is John Snow's removal of the Broad Street pump. So this is very classic epi. This was somebody who was tracing, I think, a cholera epidemic maybe, and through geospatial mapping was able to see that the area surrounding this particular water source had a higher incidence of the disease. And so changing the water source would probably help stop the epidemic. So people quibble with all the historical details, like maybe the outbreak was already waning, but still, his fundamental epi was right. And so I said, would we be talking reverentially about John Snow if he'd done a study of individual level risk factors for cholera death among those admitted to the regional hospital? And so this is expressing some of my frustration with what I saw to be the prominent narratives and study designs in epidemiology, like saying, okay, we have these people who are showing up at the hospital and let's do a bunch of studies about who's more likely to die. But as a population researcher thinking about larger transmission dynamics and burden, we need to step back a level. Why are these people ending up in the hospital in the first place? And so we wrote this paper. It's a very big paper. It's a lot. So I kind of have an outline on the left side. And it actually grew from a collaboration with Elizabeth McClure, who was a PhD student at the time, who had done her dissertation research in a community-based way about occupational exposures for workers at an aluminum smelting plant in Baden, North Carolina. And so this plant is now closed, but a lot of the people who live there are worried they have increased risk of cancer and other health harms because of their work in this factory. And so, Libby's very creative and, did community-based work, did the traditional epi, looking at job roles and later cancer risk. Her papers are published and they're fascinating. But she also did this other side project about workers' compensation and lung function. So in doing her work, she ran into the fact that's now pretty widely known that there's all these racial corrections in lung function. And so to decide who gets workers' comp, you look at how impaired a person is, and a person has to be impaired over a certain threshold to get workers' comp. But a Black worker had to be more impaired to get workers' comp, because there is this race correction that said, well, Black workers just have less lung capacity inherently. And so there's been a lot of work now on this over the past year, but at the time when Libby was doing her work, it wasn't that widely known as it is now. And so I said, I really see a connection between the work you've been doing and what we're seeing in COVID. And so the structure of this article is actually to start with a quote from the indictment of the person who strangled George Floyd to death. The odd thing about this indictment is that it's a criminal complaint against somebody who's accused of killing somebody else, but a prominent part of this complaint is actually listing the health conditions of the person who was murdered that really didn't have much to do with the cause of the person's death. And I think it's really emblematic of this individual level approach to trying to identify susceptibility of all the people who suffer poor health, to really situate all of the cause of their poor health in their person versus to consider all the forces that led to their poor health. So then I go on to develop the argument with my colleagues that the impact of this individual level risk factors, I think about the impact of that focus through the lens of structural racism, racial capitalism, and the inverse hazard law. And the inverse hazard law is a theory about who gets exposed to occupational hazards. And that'll come back around in the COVID-19 section. And so then we use a case study that Libby made about the fact that there is a race correction in lung function where epidemiologic data shows that perhaps Blacks have worse lung function on average, but there's not a race correction for hearing, where an equally robust body of epidemiologic knowledge shows that on average, Black adults have tended to have better hearing than white adults. And we talk about the implications of this discrepancy, the application of the race correction in one domain but not the other doesn't make any scientific sense, but it does make sense if the goal is to maximize industry profits and reduce their payouts under workers' comp. So then we talk about case studies of COVID-19. Even this summer, it was very evident to us that COVID-19 risk was really occupationally situated, that so many people who got COVID-19 got it at work because you have a network of unrelated people mixing. And often the people who were at the most risk were people who were low wage, who had person-facing jobs, did not have adequate PPE. And you can see something like the inverse hazard law that says that within any organization, risk is not equal because some people are given more safeguards than others. So you think about medical doctors. In the current climate, medical doctors in a good, well-functioning health system working with many COVID positive patients have a very low risk of contracting COVID because there are the safeguards to prevent their infection. So they're highly exposed, but they have relatively low infection levels. But over and over again through the summer, we would see evidence of janitors and mail clerks and other hospital staff, low-wage hospital staff who were dying of COVID and getting infected at work. And that's not a case of, oh, these jobs inherently have high exposure, because the doctor's jobs have high exposure too. It was a case of prioritizing the protection of some people within a workplace more than others. So that's the argument we made, and we argued that a lot of that very much goes with race, ethnicity, and immigration status, and we give several examples. And we call for a refocus on structural causes of health, including occupational hazards in the structure of work. So that's kind of my talk. Really just reflecting on my long-held values about wanting to do work that matters to somebody, and thinking about how I've prioritized my time over the past year, trying to think, where can I add value and bring something that's unique? Thinking about being called to meet audiences where they are, to share knowledge that I think is important and actionable, continuously reevaluating that in myself, and even being critical of the field to call us to do things that are better. So in addition to the support that I talked about for the seroprevalence work, I've been supported by other organizations and institutes. I'm really grateful for their support and the colleagues that I have in being able to do research. Thank you.
Thank you for this really wonderful and thoughtful presentation that I think touches on so many different themes and aspects of work and life and everybody's experiences during COVID. We have a lot of time now, and I'm thinking that if we could start with some comments and questions in the chat box, we can somehow navigate a conversation among 100 participants on this call. So I will keep an eye on the chat box for you, Whitney, and bring some questions, but I'd love somebody to get started. Aside from the thanks that I'm seeing in the chat box, I think Pat Remington shared your Twitter handle, so you'll probably have a little minor blip in the number of followers after today. But I'm wondering if somebody wants to either unmute themselves right now or tap something, put something into the chat box to get us started.
I'm happy to talk more as well. You know, I do like having a lot of conversation, and so I purposely left time. But, you know, I think in my abstract, I really hinted at how this year personally has affected me. Like, I've had many family members sick with COVID. I've had many family members who work in jobs where they have to show up every day, and, you know, hearing public health people say, just stay at home, and thinking this is not relevant advice for the people in my family, and wanting to push us as a public health community to give advice that's more relevant. And even that last paper, I kind of like wrote it in a rage because it was right after one of my uncles died of a pulmonary embolism of COVID. And I don't feel like he got good care. And I feel like if you look back at the chain that led to his infection, you know, it was structural things. And so, you know, I love my work, but I'm also just angry about how this is all unfolded.
Yeah, you know, I'm reflecting on the really, you know, wonderful opportunity you have living in a neighborhood that is so engaged. And I'm wondering, before we get started with the questions, if you could talk a little bit about what you heard from your neighborhood that may have influenced your perspectives and your work.
Yeah. So many gems. I mean, really trying to follow their lead. And I mean, early on, people were concerned. I feel like sometimes there's this narrative that, you know, minority communities are not concerned about their health. And I didn't hear that at all. I heard people making great sacrifices to try to protect themselves and their family and just wanting more information. So I talked early on about maybe doing a contact tracing because we're very concerned about the university reopening. Famously, UNC decided to bring back all its students in the fall of 2020 without adequate mitigation. It ended up within about a week spiraling into a big outbreak. But before they came back, community members were really concerned. And so I'm like, well, maybe we should do some contact tracing. And so something that came up, a lot of the older residents said, I have really bad associations with contact tracing because they had known it through STI contact tracing and had bad interactions with public health authorities around that. And so that was interesting. As a public health person, I'm thinking, oh, this will be great. And so I really stepped back in hearing that. And so I think I've just learned a lot and tried to ask, okay, what's most useful to you? Mm-hmm. And so sometimes it was kind of knowledge and advice, and I'll have people call me up. There's now a partnership where, we're having a hard time helping people get vaccinated because again, people are trying to, I have an 80-year-old neighbor. She's like, I don't have a computer. Like, how am I supposed to navigate the system? And she's trying to call around and it's so unclear. And so one of the people in the neighborhood organization had a friend who worked in the healthcare system who got some slots for older people in the neighborhood. I don't know if that answers your question.
Yeah, but I think that was helpful. I'm gonna ask Kristen Malecki to unmute herself.
Sure. Hi, Whitney. It's nice to see you again. Thanks so much for this talk and raising these really important issues. I think, you've been to Wisconsin, Madison, we're largely this white group of very well-meaning scholars who want to do well in the world. And I wonder how you help your other public health colleagues, right, who all want to do the right thing, who also don't have some of the shared lived experiences that people of color who have extended family and communities of color so I have the sense that how do we bring ourselves together as opposed to divide more around the lack of shared experiences in dealing with this? So and this comes up because I saw it in the school board meeting earlier this week. There were a group of parents really, really advocating for the mental health of the entire community to get low risk sports back into the Madison schools. And it turned into a divide between people saying, you don't understand our shared experience, you don't know what you're talking about, we don't want to kill our babies, and other people saying, wait, no, I think we should all get back to school. So I don't know if from your perspective as a scholar who grapples with this has any advice for all of the rest of us well-meaning white folks.
I mean, school stuff is its own thing. And I'm actually thinking about writing something about this because I think that something that comes up in both contexts as far as research collaborations and school stuff is this idea of, if you haven't been there for us before, don't try to talk on our behalf now. And so that's something that's very central in the schools debate. And when people kind of appeal to racial equity, and it doesn't feel true if it's not somebody who's been invested. And often people who've been invested aren't going to be speaking for people. They're going to be trying to facilitate people to speak directly. And I think with colleagues, there's some of that. Now there's a real demand. People are like, oh, what you do is interesting. And I'm like, what I do has been interesting for a really long time. And some people have seen that. And so I'm going to always prioritize those relationships with the people who have been working with, for a longer time and who have seen that value. So the seroprevalence work was with my colleague, Allison Aiello, and Allison's been amazing and always been supportive and really seen the value of the work I do. And so Allison asked me to do something. I'm like, yes, let's do it. But there's sometimes only so many hours in a day. So I try to think about how I can help in a way that adds value. So that question of adding value. So somebody asked me to consult about a project, I might say, look to this person or think about this, but I often can't get involved in everything I'm asked to do, especially if we don't have an existing relationship, because it's honestly sometimes so much work to try to get somebody up to speed. And it can be really hard when my capacity is so limited as somebody trying to live through the pandemic. I do think another piece of advice, I've sometimes had people approach me and they're very urgent about what they want. And they're respond to me, I need your response now. And that really makes me shy away from working with that person because I'm like, we're living in a pandemic. I have family who are literally dying, like I'm trying to take care of small children, like also some awareness of what other people are going through, even if you're doing okay. And I think, those colleagues, I have people who will approach me about doing something and maybe I don't get back to them for a while, but they get it and they try to think about other ways to support me. And that's a relationship that ends up having more fruition than the ones where I feel like people are being very demanding of my time without thinking about what I'm going through. And so, yeah, I think there's a way to do it, but it's often not something that's easy to do quickly. But I try to contribute to the extent that I can.
Yeah, so Whitney, what I guess I'm hearing you're saying is that we all need to just continue to build respect for one another and trusted relationships, and those will help us in terms of sort of moving forward as colleagues and people, and that you're drawing towards those trusted relationships and in prioritizing moving forward. That's great advice. And can I ask you another quick science question? Yeah. Since I asked you that kind of the antibody surveillance work. Yeah. How are you going to move forward? So do you know what you're going to do? You may not know the answer to this. Maybe this is for Dr. Ayo, but so the vaccines produce different immune responses that can be tracked over time than sort of some of the other previous antibody surveillance. So do you know what test you're going to be using for looking at vaccine protection?
I always defer to my lab colleagues. So I'm the PI of this study. Allison helped usher me in, but I am the PI. And my lab colleagues are amazing, and they've developed their own ELISA platform with the specific markers they look for, and they're actively developing other assays, and they have different assays. There's different labs that use slightly different assays, and so that's an area where we're still working together.
Super, thanks.
Pam, Deb,
Janine, it's good.
This is Gloria. Could I ask a question?
Sure, go ahead, and then next up will be Janine Dilworth-Bart.
Since it was a football weekend and I happened to come upon an instance there, a Black football player who has had decreased mental functioning, as so many of them do because of all the concussions and head injuries. But what's happening right now is they're measuring the deficit that occurred during their lifetime, and they're using different levels for the white players as opposed to the Black players, and which results in the Black players getting far less money for what's happened to them. And I don't know if maybe you've been hearing that or following it, but it's something I think that is really important to look at.
Thank you for asking about that. And so I talked about the different race adjustments, and
that's exactly right. Yeah.
And the lung function. And so another issue that's come out is kind of the NFL settlements. And this is a really long, sordid tale. I actually know people who've been expert consultants about this, and it's a real problem. So in the cognitive field, they kind of have developed some benchmarks and noticed that, they see kind of racial differences in the levels of the performance on these tests on average across racial groups. And so it's a common practice in a lot of this neuroepi work to apply race corrections. And so, you could put that to the side and think about, is there a better way to do it to try to get at what's actually going on versus kind of a crude race correction? That's one set of questions. But also, should that race correction be applied to this particular select population of NFL players? Because the things that might lead to these differences in a general population are not necessarily going to be present when you're restricting to a group of NFL professionals who have gone through the gauntlet to get to this specific career path. But it is the exact same principle, where a business interest, in this case the NFL, that wants not to do payouts, uses this to reduce payouts to Black players. It's totally analogous, and it's really interesting area where you have something that maybe was used in a population setting is now applied to this setting and has a direct effect on people's ability to get reimbursements from workplace injuries.
Yeah, well, thank you.
Hi, Dr. Robinson. My name is Janine Dilworth-Bart, and I am I am in human development and family studies, so I don't come from an epi lens or a pop health lens, and I've been furiously taking notes. And something that just has popped out to me is just how racism makes everything harder. And that was something that I was trying to I was describing to a colleague, and one of the things that strikes me in this discussion, and you had touched on it in this discussion about people of color, Blacks in particular, and getting the vaccine. And so maybe because the question is always about the questioner, the way that I had been thinking about this is that we talk about Black people mistrusting the healthcare system. And really what's interesting about that is that my kid's at the doctor right now, and she gets all of her physicals. And I'm a consumer of healthcare. I try to be informed and everything, but it's not mistrust. And as we've been shaping this discussion around, well, there's something wrong with Black people. And even when you're talking about, the NFL settlements, it's more than just from a biological standpoint. It's a sociological standpoint or assumption that's underlying everything, that, well, Black people are already cognitively inferior. We have to correct for that. Black people don't like doctors. There was one politician, I believe in Ohio, who said Black people don't wash their hands as well. And so now he's leading the public health effort to reduce COVID in minority communities. And so it really just seems like with the vaccine, Black people don't trust doctors, and it's never been twisted the other way around and say, actually, health systems don't treat Black patients well, and they treat Black patients poorly. So that's not a question, it's more of a comment. But it was something that I really felt sort of summarized for me what you were talking about.
I have a vignette that's relevant. So so I've been really, pro-vaccine with my family. My husband was in a trial, and so I talked about it. And I have a cousin who's, young. She works for a hospital, and she said, I'm not getting the vaccine. And I was like, why? And so she had a few things. She talked about allergy response. This was early on. And I'm like, that's like legit. That people are trying to figure out kind of allergy response. And somebody's had a lot of allergic reactions. She said, I don't like people telling me what to do. And I'm like, that is true of you and real. And there was something else, and she's like, oh, I'd already had COVID, which is true. So my cousin works doing customer service on phone calls every day in a health system. And so she's not a dumb person. She knows that being in a room with other people talking on the phone every day is a very risky situation for the spread of SARS-CoV-2. And so she asked her hospital, her employer, if she could work at home, and they said no. And she and her coworker had to keep coming to that small room and making those phone calls, and they both got COVID. And she had spread it to her whole family, because that's how it works. And so now this same health system is saying, take this vaccine because we care. And so I don't know what to say to that.
Yeah, no, I appreciate that. And I think that is, we engage in that way with workers, with communities of color, across settings. And so, but we're not going to address an issue until we stop, basically blaming the victim. You distrust us, therefore you're not going to get this gift that we're giving you. But we received some gifts in the past, and they were not all shiny and wonderful. And so I think that is something that is sort of inherent in a lot of what I'm hearing you say. But thank you for your presentation. I really appreciated it.
So the next person is Marie Elizabeth Thomas. Go ahead and unmute.
Hi, Dr. Robinson. Thank you so much for your talk. I also want to say I'm a huge fan of Acadames, and I listen to it all the time. I fell off a little bit during the pandemic with the kids, but my question is, I'm also a reproductive and perinatal epidemiologist, so I also admire you for your research and your work. And I share the same frustration that you mentioned with the rollout of the vaccines around this age distribution and not focusing on populations at risk. And so my question, or those who are at higher risk of exposure, And I was wondering if you knew of any public health departments that were actually focusing on that in their rollout, or like ways to do it, or even other countries that are doing it based on that approach rather than this other kind of stagger. Because I know here in my state in Maryland, it's been very frustrating, the rollout.
Yeah, I think there's a few issues. Like one is the actual prioritization, like what's down on paper. And so it's been super contentious. I talk a lot about Ron DeSantis in Florida, who was like, vaccine for everybody 65 plus, when there's not enough for everybody 65 plus. So what does it mean when you say everybody's eligible when you know you don't have enough for everybody? And so just actually what you put down on paper is important. But then there's also the logistics of how you do it. I mean, you can say, oh, this is equally accessible for everybody, but if it's through some like online system that's super hard to navigate, is it really accessible for everybody versus working through community organizations that have ties? And so I think there's a lot of innovation actually with working with community groups. Like I talked about my neighborhood group and kind of a tie with, you know, people who work with the health system, who are in charge of a large facility. And it's still using the 65 plus rule, but saying to him, like, we know the people in your neighborhood are not going to be able to navigate the system because it's awful to navigate. If you can find them and like round up their names and help us get the information, like we can set aside some spots for them. Instead of them having to go through the system that is just not really meant for them, that they are going to have a hard time navigating. So some of it is the logistics of going to people and saying, what would be the easiest way for you to be able to get access? And I think some people are starting to do that. But honestly, it like gets to be politically contentious. This seems so basic. It seems so like these are the people who are most likely to be affected. These are the people who are having the hardest time get access. But sometimes when communities and public health offices try to say, well, let's try to, you know, prioritize getting vaccine to these populations, people who are wealthier, often whiter, like object to it. Like just absolutely object to it. There is political pressure not to prioritize the most affected populations. And that's a hard thing. So I think there are some success stories, but I think weirdly, a lot of these places are quiet about their success stories because they don't want to get community pushback, which puts us in a really hard space in understanding, you know, best practices. That's just my impression. I don't know what if other people have a different sense.
Thank you.
So we're at the end of the hour. This has been a fabulous conversation, and I can't thank you enough, Whitney, for joining us today. It's been extraordinary getting to hear from you about your perspectives and your work. It's really inspiring. And I want to encourage everybody to follow Dr. Robinson. And we're going to be sharing some material she sent about some of her writings and her blogs and podcasts, I think through Pop Health, but also on the PRC website. So that'll be a good place for you to go to get access to some of this. So anyway, if we can figure out how to applaud and just kind of show our thanks, it's been tremendous having you.
Thank you. I look forward to speaking to some students this afternoon, and I really appreciated the visit. Thank you.
And I just want to do a quick plug. If anyone is missing the calendar invitation, just email me and I'll send that to you again for students.